We're going to start today with the first topic. Dr. Bassam Abul Banat, a very good friend and colleague. Dr. Bassam did his postgrad in London, Ontario. Very excellent cardiologist, hard worker in Amiri Hospital. Contributed a lot to the continuous medical education. He's going to talk to us about the dyslipidemia, where we have lots of problems between the new guidelines. So, Doctor.
Thank you, Walid, for the introduction. Thank you very much for inviting me to this lecture, and I hope that whatever we're going to discuss is going to be something that you're going to use in your clinical practice, hopefully. Now, this is a bit a dull area to talk about when we talk about lipids. So it's a bit dull and a bit dry. So the way that I'm going to do it, we're going to do it as a story. So that's the whole idea. The goal of this topic is not to tell you what lipid to use. No, actually, this is not like lipid agent to use. This is not the idea of the talk. The idea of this talk is that by the end of the talk, each one of you should have a tool to help you deciding when to treat, who to treat, and how aggressive to treat. And actually, you're going to probably discover that for the same patient, if you are living in Kuwait, you're probably going to treat a patient in a certain way. If you're living in UK, you might treat him in a different way. And if you are living in North America, you might treat this patient in another way. And probably, there is no, black and white. You're probably going to be all right, but you have to put all of this in context. So I'm going to start my talk. The outline is going to be, we're going to talk about the controversies. Then we're going to touch the guidelines. I'm just going to show you a bit of the key trials about the guidelines, and just to understand the differences between the European and the North American guidelines. Then I'm going to show you some basically twists with regard to some areas of special patients, especially the renal patients, because that's important in diabetes. And finally, I'm going to show you some stats with regard to Kuwait, so that you understand, if you have a patient, you are living in Kuwait, so that you understand how your patients are different from the rest of the globe. So we're going to start with chapter 1, and that's the controversies. I think this is probably the best statement that came to describe the controversies when the new lipid guidelines came in North America. And this is actually from the American Association of Clinical Endocrinology, which I'm going to refer from now onwards with ACE. This came in, basically this statement came in December of 2013, so about almost 2 years now. And it just came after the approval of the new lipid guidelines. So I'm going to basically state to you what they have mentioned. ACE welcomes the intent of the HAACC in the creation of these new guidelines, but does not agree with the complete content, and therefore cannot endorse them. The association stated, the rationale behind this decision primarily comes from the incompatibility of new guidelines with ACE existing guidelines, questions over new scientific evidence behind the new guidelines, concerns that the populations of patients at risk from disease may be underserved or ill-considered using AHA-ACC guidelines. The statement continues stating that these new guidelines focus exclusively on large-scale randomized clinical trials. They are highly restrictive regarding the database considered, and on which much new information, no research after 2011 has been considered. Actually, they were talking about non-statin medications. Taken together, these actions have resulted in a considerable number of at-risk patients being omitted from consideration. The risk calculator for coronary heart disease released in the guidelines is based upon outmoded data, does not model the totality of the US population, has not been validated, and therefore has only limited applicability according to the ACE. While ACE agrees with the use of full-dose statins for dyslipidemia, the organization disagrees with the removal of LDL cholesterol goals and the idea that statin monotherapy is sufficient for all at-risk patients, non-statin agents may be needed in combination with the statins in very high-risk groups to produce adequate LDL cholesterol reduction to further reduce CHD risk. Failure to set targets for treatment makes the degree of risk reduction produced in these groups unknowable and eliminates proper monitoring of management. Worse, it diverts attention away from the ongoing disease process and may lead to unjustified complacency regarding disease recurrence and its prevention. And the statement concludes with this: we recommend that ACE members continue to refer to ACE guidelines and position statements on lipids and obesity to assess decision-making in their practices, the association has stated. The reason I started with this statement, this is a North American association, and it's quite a respectable association. And they have stated this quite strong, actually, points against the ACC-AHA guidelines. How about another twist now? Now, what about the North American versus the European Society guidelines with regard to lipid management? There are points of agreements, and there within certain points of agreement, there are some issues of disagreement with regard to the specifics of those points. Both societies, basically, they use lipid-lowering drugs should be based on the assessment of overall cardiovascular risk rather than simply on a perceived need to treat an abnormal level. So basically, both societies agree on that point. High-risk people include those with manifest atherosclerotic cardiovascular disease, familial hypercholesterolemia, and diabetes. The third point is that in people without overt atherosclerotic cardiovascular disease, familial hypercholesterolemia, or diabetes, a global risk should be calculated and used to guide a treatment decision. Now, here where it comes the problem between the two societies, or the guidelines, basically. In the European guidelines, they thought, especially for the primary prevention group, which we're going to come later on to, they think that the Americans have used a bit of sort of a very low threshold, and that is why the Europeans believe that the Americans have treated some 30 million individuals unnecessarily in the primary prevention group. So that's one of the differences that it comes. The tools used to calculate the overall risk is a bit different between the American and the European guidelines. Both societies, they basically concur that the calculation of global risk should take account of both lipid and non-lipid factors, and there should be a major emphasis on lifestyle intervention. They so both agree on that. Now, LDL should be the primary therapeutic target, and that's, again, I think for me this is a fundamental change between the two guidelines. Yes, they state the same. If you look for the American guidelines, actually, if you go to the high intensity and the moderate intensity, they don't ask you to look at the LDL, especially in the high intensity. They tell you just to start the maximum dose of whatever statin, Lipitor, or atorvastatin or rosuvastatin, and then you don't have to look at the LDL. They are telling you that the LDL is the target, but actually they're using sort of a hit and run, or basically fire and forget philosophy to that. So there is a difference between the European and American in that mode. They both agree that the statins are indicated in the proven high-risk conditions, which we have stated before. Now, they both agree that when the risk is high, you should go with an intensive therapy. In the European, by intensive, we are aiming for an LDL cholesterol level less than 1.8. In the American, we talk about an LDL cholesterol reduction more than 50%. And when the risk is moderate, you're going to go with a moderate intensive therapy. In the European, we talk about LDL reduction less than 2.6, and in the American, we talk about a more than 30%. So it's going to be 30 to 50% LDL reduction. There is general agreement that non-LDL cholesterol should be considered as an alternate to LDL cholesterol as a therapeutic target. So the points of disagreement, each society uses different algorithms to use to calculate the risk. They both agree about calculating the risk, but they are sort of using different algorithms. The ACC-AHA version does not identify targets for LDL. ACC/HA guidelines tend to de-emphasize non-statin drugs. And you're gonna, down the road, you're gonna see something new, which I'm gonna show you later on, just to show you that. So in conclusion, there are many points of agreement with some points of disagreement with recent guidelines for the management of plasma lipids. All agree that LDL cholesterol is a primary target for therapy to reduce atherosclerotic cardiovascular disease. All agree that treatment decisions should be based on the overall cardiovascular risk rather than plasma lipids alone. So that's chapter 1. Let's go to chapter 2, which is the guidelines. Now, with regard to the guidelines, your patient is going to fall in one of those groups. So you're going to be treating a patient in your clinic, be it a polyclinic or as a general internal medicine or a cardiologist or an endocrinologist. Your patient is going to fall in one of those groups. Either he's a primary prevention, or he's a diabetic with primary prevention, or he already has overt atherosclerotic cardiovascular disease, including stroke, or he's in the secondary group. So you have 4 clinical groups that you're going to be encountering. The primary prevention group is the group that we have talked about, is that there is the difference between the two societies, how to deal with those patients. In the European, in the ESC guidelines, basically, they are dividing them into a moderate and a high-risk group. The moderate risk group, we are aiming for an LDL cholesterol less than 3, and in the high-risk group, we are aiming for less than 2.5. When it comes to the ACC, AHA, and the ASA, American Stroke Association, you're going to see the estimated 10-year atherosclerotic cardiovascular risk being more than 7.5%, with the cholesterol margin being 1.8 to 4.5. In the European, we talk about in the high risk, less than 2.5, and in the moderate or mild risk, less than 3. And that's where the discrepancy is happening, is that you are having in the American probably some people that you would not treat if you are using the European guidelines. And that is why probably the American, like if you use the European guidelines, you're not going to be treating some people in the States. And those are basically a summary of the, it shows you how that on treatment LDL is closely related to coronary heart disease events in the statin trials, be it primary or secondary prevention. This is a famous slide, and I think all of you know it. And basically, again, it's stating that LDL reduction is important. We should be looking for LDL reduction. But the two societies, they go with what's the level, and there is another society looking at the intensity of statin treatment. What about which statins help you in achieving your goal? For the primary prevention, you're going to discover that atorvastatin, rosuvastatin, and simvastatin probably are the 3 major statins which are going to help you on that. And that's again shown in the LDL lowering in the NICE as well. So there is no problem between the two. Those are the statins which have been used in primary prevention for cardiovascular events. Just to show you the major trial, this is the ASCOT LLA. So there is and this is a trial, they used atorvastatin 10 milligram, and there was a 36% relative risk reduction of primary endpoint of non-fatal MI and fatal CHD compared with placebo. And the same thing happens with rosuvastatin as a primary prevention. So the use of rosuvastatin decreased the time to first major cardiovascular event compared to placebo by about 44%. What about now primary prevention in somebody who's diabetic? So if we go to the European guidelines, we talk about basically uncomplicated type 2 diabetes mellitus. So you have that patient is diabetic but does not have other risk factors. The aim here is to go for LDL cholesterol reduction less than 2.5. If you have other risk factors or end organ damage, then you're going to be aggressive. So you're going to go to less than 1.8. When it comes to the Americans, they divide them. It's sort of almost similar to the Europeans, but they use their overall risk estimate, which is an estimated 10-year atherosclerotic cardiovascular disease risk. If it's more than 7.5 and your LDL cholesterol is anywhere between 1.8 to 4.9, then you're going to be in the high intensity. And if it's less than 7.5%, your estimated risk, then you are talking about the moderate intensity. So here they are not that much different, but the big difference was in the primary prevention. And again, if you're going to look for the statins, which have been proven to achieve that, that's going to be reproduced again and again and again. And both societies are the same. Now, to look at the studies which have looked into these entities, that's somebody who's diabetic and you want to basically decrease their cholesterol. Do we have any evidence that it improves incidence of major cardiovascular events? We have in the CARS trial. CARS trial was basically primary prevention of diabetes with one or more risk factors. So there is a 37% reduction. Then you have an entity where you have type 2 diabetes and 2, so that's a higher risk patient, more than 2 additional risk factors. Again, that has been proven that you're going to achieve about 23% relative risk reduction in the combined cardiovascular endpoints. What about if you have now basically somebody who's diabetic and ACS? Again, statin have been shown to decrease the combined endpoints. Now, saying that still your diabetic patient, even if you are using statins, the diabetics compared to non-diabetics who are hypercholesterolemic, still, yes, you are achieving better, you are decreasing the combined cardiovascular endpoints, but still the diabetics, they do worse. So is there something else we can achieve? Yep. You can actually use a higher dose of a statin, and this has been tested in the TNT trial where they used an atorvastatin 80 compared to 10, and that really addition did achieve further reduction in the relative risk of the combined endpoints. Let's go now to the third group, which is the atherosclerotic cardiovascular disease group. Those are who have an overt atherosclerotic cardiovascular disease, including stroke. And here, the guidelines are almost the same, because here now we are talking about the European, we talk about a very high risk. Your LDL you are aiming for an LDL reduction less than 1.8. And in the Americans, they are talking about, again, a high intensity, except there is one exception. In the American guidelines, if your patient is older than 75 years of age, then they ask you to just go on the lower dose of the statin using, for example, Crestor 20 or Lipitor 40 because of the risk of transaminitis of those patients. So that's the only difference. There is an age cutoff in this group. But both of them, they agree that this is a high intensity statin therapy. And again, the same thing is repeated again and again. And those are the big trials which we basically looked at the statins and the overt atherosclerotic cardiovascular disease. That's the Miracle, and then Prove It, and the TNT, okay? Now, up to this stage, actually up to last year, the European guidelines, they were saying that we need to look at the basically non-statin medications, but we were lacking the evidence. And until the Improve It came, the results of the Improve It came, so that was a significant trial, because this was the only trial up to date that has shown that a non-statin medication would lead to further reduction of combined cardiovascular end results. So basically, this shows you that there was a further reduction of the cardiovascular death, MI, documented unstable angina requiring rehospitalization, coronary vascularization, or stroke in patients who are receiving ezetimibe on top of simvastatin compared to simvastatin alone. And this basically to break down for you the combined cardiovascular endpoints where we're gaining most. Actually, you can easily see that it's the addition of ezetimibe led to decrease in the MI, stroke, and ischemic stroke. However, the overall cause of death, probably there was no difference between the two groups. So the big addition is giving you is that to decrease the ischemic events with regard to the heart and the brain. And the most important thing here, because we are afraid of side effects actually, you are adding another medication to a statin, so people are worried about renal, transaminitis, There is always this concern is that if you decrease your LDL really down, cancer, especially this trial went up for 7 years actually. So you have a good guesstimate about if there is any risk of having cancer. So luckily there was nothing to state here. And the importance of this trial, this is basically the new guidelines. They just came about a month ago in the new new ACC in the new European guidelines. So for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation. And basically what you can see here is the second point. The guidelines clearly state in patients with LDL cholesterol above or equal to 1.8 millimole per liter, despite a maximally tolerated statin dose, further reduction in LDL cholesterol with a non-statin agent should be considered. And of course, here down in the index, they say that at the time of finalizing the guidelines, this recommendation applies only to ezetimibe. So I think it just tells you that if you had one study and within just probably less than a year, that study changed a guideline. So basically that again states for you that the Europeans thinking that the non-statin is important as the statins, and that's why I think they included it in the guidelines. For the ST elevation MI, of course, we know that a statin, the evidence for the atorvastatin 80 milligram is quite obvious. The final group is the secondary prevention group. Again, there is almost no major difference between the two societies with regard to their margins of treatment. This is a high-risk group by no means. So basically, we are talking about optimal LDL cholesterol control less than 1.8, and when it comes to the American, they are talking about the same thing, high statin therapy. This is a summary of the secondary prevention clinical trials. I think most of you know, I mean, all of you know about those basically trials. We're gonna skip that. Okay. Now, what data is available regarding the safety of higher doses of statins? Because now we are talking about moderate and high intensity statin doses, so you should be aware of which statin is safe for your treatment. And again, if you're gonna look at the transaminitis, probably the safest is gonna be rosuvastatin. Then we're going to talk about atorvastatin and simvastatin. In UK, if you remember that few years ago, because we had some quite a big number of transaminitis with the 80 milligram dose, so the 80 milligram is taken from the UK markets. We only have the 40 milligram simvastatin. And that's because of that, because we had a big chance of having transaminitis. So basically, when it comes to atorvastatin, again, with atorvastatin, the risk of transaminitis goes a bit higher as you touch the 80 milligram dose. So you have to be careful with that, especially in the elderly. Now, honestly, I mean, in my clinical practice, I think that's probably a common thing as well. Below the age of 75, probably we're not seeing it much, but after the age of 75. And remember, those patients, they are on, like, probably they're going to end up at least on 10 or more than medications. So again, drug interactions happen. There are things that we are unaware of. There are new antiplatelets coming on. You don't know what's the interaction with the new lipid agents. So you have to be aware about those things. What about the muscle effects? It's almost the same. Rosuvastatin is the safest, followed by atorvastatin and then simvastatin. Let's have another twist now. What about the renal patient? Now, just to give you an idea, it's about almost 40% of your type 2 diabetic patients in clinical practice, they will have some sort of renal impairment, be it incipient or overt. So you have to be aware of that. This slide, I like it. If you remember, there is a slide which shows you that if you had type 2 diabetes, it equals as if you had a heart attack. It's the same thing here. If you are diabetic and you have chronic kidney disease, your basically cardiovascular event rate goes up from 7.8 for somebody who's not diabetic without chronic renal disease, and it goes up to 17.4%. It's almost the same percentages with the type 2 diabetes and coronary disease. It's actually acting the same. That is why Now, people are considering chronic renal failure or renal impairment, let me say, is a risk factor, independent risk factor for cardiovascular disease. So it is important. So those patients are basically high-risk patients, the chronic renal impairment. What do we know about which statins are safer to use in chronic renal impairment patients? We don't have prospective trials, so that should be very clear in the mind of everybody here. What we have is that the TNT, it looked as a post hoc analysis. Post hoc analysis is statistically, you're doing it after the study. And it's a bit weaker than if you have it as pre-specified group to start with. But that's the evidence that you have. At least you have something to go with. So the only thing that we have about is that atorvastatin, and in chronic kidney disease patients, it's again, it did decrease the relative risk for cardiovascular endpoints by about 33%. And this is the percent change from baseline in GFR and the TNT patients by chronic kidney disease. So this is basically to show you that the addition of atorvastatin did not decrease the GFR, so it did not worsen the kidney function. That's what at least we know about. There is a trial, that's the PLANET-1, which basically looked at the renal effects of atorvastatin versus rosuvastatin in patients with diabetes who have progressive renal disease. And basically, in this slide, we can see that rosuvastatin versus atorvastatin 10 and 80, they were equivalent, but the rosuvastatin at 40 milligrams specifically, it did not protect the patient. And when it comes to the GFR here, we can see that the atorvastatin 80 milligram and 10 milligram, they were equivalent, but the rosuvastatin at 40 milligrams, it did decrease the GFR. And when it comes, again, the same thing here is just to show you the same thing, that rosuvastatin at 40 milligrams significantly decreased GFR versus baseline. This is basically, the slide shows you the summary of renal adverse events in patients who are on rosuvastatin 10, 40 versus atorvastatin. It seems that rosuvastatin 10 and atorvastatin 80, they are not having adverse renal effects. However, if you are using rosuvastatin 40 milligrams, it seems that it's probably not doubling actually, probably 4 times causing further renal impairment. It can lead even to acute renal failure. So you have to be very careful when you are using a statin in renal failure patients. So the evidence right now is that probably atorvastatin is safest. If you're going to use rosuvastatin, 10 milligrams should be okay, but definitely you should stay away from the 40 milligram rosuvastatin. Now, one last twist. You're going to see every now and then a patient hits your clinic, and this is an elderly lady or gentleman on a wheelchair. They had their breakfast, and you did not have a blood work for them for quite some time. Would you wait for those patients to fast to come on another day, or can you do the blood work even if they did not fast? Do we have any evidence that can help us in basically looking at those patients? If I do a full profile, would that be okay or not? This is basically a big trial which was done in the States, actually came from the University of New York. It was published in July of last year, actually. This is an excellent trial. They looked at 20,000 patients, actually, and they looked whether if you do a blood work, if you manage the patient based on a fasting cholesterol profile versus a non-fasting cholesterol profile, would it make any difference? And actually what they have discovered is that higher non-fasting and fasting LDL cholesterol levels were associated with an increased risk of all-cause and cardiovascular mortality, and that both, meaning fasting and non-fasting, yielded similar results for the prediction of mortality. Actually, I've changed my practice since that trial. Nowadays, I'm getting patients in my clinic. Honestly, they cannot go and come every now and then to take the hassle of doing the blood work. The other thing, remember, your patients are diabetic. If they fast for 12 hours, that's the usual thing we are doing. Some of them, they can have hypoglycemia. Some of them, during those 12 hours, they can go into pre-renal, actually. You're going to see a mild increase in the bun. So if your patient is not fasting, do it. I mean, I'm doing it, but honestly, I'm not telling the lab. I mean, this is a trial and has been shown that you can use that. So this is the finale, basically. Just I'm going to give you what are the data that we know about Kuwait. If you are living in Kuwait, are you going to treat your patient aggressively or complacency? I'm going to give you some data about our recent registries, and it's going to help you to have a decision by the end of the talk. This is basically the Ephesus Gulf study that was published in about 2009. And in this study, we have discovered, that was in the Gulf area, basically. We discovered that about 59% of our primary prevention patient group only receive treatment according to guidelines. They are within the guidelines. And if you are in the secondary group, only 33%. They are the high-risk group, remember, huh? Only 33% are, their cholesterol levels are within the guidelines. Okay? What about ACS? If we're going to compare our population with ACS compared to the European, registries, our patients present with ACS younger than the other registries by about 5 years, which is the Gulf Coast. So our patients hit the ER with ACS with a mean age of 60 compared with a 66 to 65 in the European counterparts. So our patients presenting earlier. They are not treating well with regard to cholesterol management. What about atrial fibrillation? The same thing. Their mean age is 57. European registries, somewhere around 65 years. And 30% of those patients are diabetic. That's AFib, not ACS. If you look at the European numbers, those go around 13%. It's a big difference. 30 versus 13. Finally, heart failure. That was just published about 6 months ago. That's another registry that we have done. And I want you to concentrate on the blue line up in the figure A. I don't have a, so just look at the up line, blue line, and then the red line. They are going against each other. The blue line shows you the age. The first dot is Kuwait, and the rest are the rest of the registries. Again, our mean age is about 60 compared to 70 of the other registries. So it means that our patients present to the hospital with heart failure 10 years younger than the other registries. And of course, diabetes is about 50% compared to probably 30 and 40. So this is my last slide for you. That's the reason I told you, if you are living in Kuwait, you might act a bit differently. There is no right and wrong. You have to see how you're going to manage your patient according to his cholesterol profile, his risk profile, and it's not necessary that you're going to basically following the European or the American. And actually, I'm a cardiologist. I'm not basically saying that this guideline is better than that guideline. But what I'm telling you, I believe based on what we have, we should be individualizing our treatment. We should be sticking for the general guideline. If you are living in UK, in the States, in Kuwait, you should understand the controversies. It's up to you to go with or against whatever guideline, but you should understand your population that you are in. So in Kuwait, we have a much higher risk population. They are presenting younger than the other registries. And basically, that's what I had to say. I hope that I have delivered the message that I want to deliver clearly. Thank you very much.
Thank you. Sorry. Thank you very much. So we'll open the floor for questions, if there is any question. Okay. So, Dr. Bassam, do you really follow the new guidelines in your daily work?
I tell you what I do. See, it's important that you understand what's happening between the European and the... I didn't mention something else about the European, actually. When the American guidelines came, There was another, basically, if you'd like to say, row against those guidelines, because nothing was mentioned about the triglycerides, not because of cardiovascular. That's what the American Association of Endocrinology were stating. They were looking as well for the hypertriglyceridemia with regard to acute pancreatitis. So again, they were saying that it's not only the patient is not only like, coronary disease, he has other things. So for me, if I have a patient who belongs to a certain family, I know certain families in Kuwait where their disease occurs really early. We are getting them at the age of 40 and they have triple vessel disease. And I know those families. So if one of them came to my clinic say at the age of 30 and their cholesterol is modestly elevated, probably in this patient I would go with the American guidelines. Yet if I know somebody of a family that they are living for a long time and they have no problems, he's okay, I probably would use the European guidelines. And that's what I meant, is that I would individualize my treatment for such patients. I'm looking for other things as well. It's not only cardiovascular. I have to look at the whole patient, and then I will decide. People might think because we are cardiologists, we might go aggressively. That's not always true, but you have to look at the whole patient. Again, and because we have now registries in Kuwait, knowing that our population are presenting early to the ER with ACS, heart failure, atrial fibrillation, we are leaning, as